Hello and welcome to Medtutors lecture series. Our lectures give tips to medical students, house officers, and young practitioners on common conditions they may encounter in exams and in practice, with an overall aim of improving the quality of healthcare delivery. Please don't forget to hit the like button, subscribe, and share for updates on more videos. We will discuss on common electrolyte abnormalities, especially in a surgical patient, and how to correct them. Electrolyte imbalances occur either from reduction or increase in serum concentrations, which normally accompanies fluid loss or gain. Common abnormalities include potassium and sodium imbalances. Potassium imbalance. Potassium is an important electrolyte which plays significant role in cellular excitability. The imbalance causes dysfunction in membrane excitability. Normal serum level of potassium is 3.5 to 5.6 millimoles per liter. Hypokalemia. Hypokalemia is a serum potassium less than 3.5 millimoles per liter. It usually accompanies gastrointestinal losses. The losses may result from diarrhea, vomiting, loss from an intracutaneous fistula, gastric outlet obstruction, intestinal obstruction, peritonitis, among others. Patient with hypokalemia presents with muscle weakness, lethargy, slurred speech, paralytic ileus, cardiac arrhythmias, hyporeflexia, and cardiac arrest. The ECG changes in hypokalemia include depressed ST segment, inverted T wave, prominent U wave, prolonged QT interval, tachycardia, and ectopic beats. Treatment of hypokalemia. In a surgical patient being resuscitated and on nil per oral, or patient with severe hypokalemia, that is serum level of potassium less than 2.5 millimoles per liter. The correction is via parenteral route using potassium chloride in normal saline or Ringer's lactate infusion. Dextrose containing fluids are better avoided because they stimulate insulin release, which worsens the hypokalemia. To calculate the patient's requirement, use the formula desired potassium minus the observed multiplied by the weight of the patient and a constant, which is 0.6, plus the daily maintenance for potassium, which is 1 to 2 millimoles per kg. However, 1 millimole is used in the maintenance to avoid overestimation and overcorrection. The correction is gradual in up to 48 to 72 hours. It should be noted that it is ensured that patient is making adequate urine and preferably under ECG monitoring. Potassium chloride should never be given in bolus. Do not give more than 20 millimoles per hour or more than 40 millimoles per liter or more than 120 millimoles per day in infusion. And one should check urea and electrolytes daily. After correcting the deficit. Patient is then placed on a maintenance potassium supplement in form of oral intake, citrus fruit, tomatoes, milk, or potassium tablets like Slow-K. Hyperkalemia. Hyperkalemia is a serum potassium greater than 5.6 millimoles per liter. It's commonly seen in conditions that cause a shift of potassium from the intracellular to the extracellular space. It occurs in renal failure, shock, in metabolic acidosis, massive crush injury, acute rhabdomyolysis, limb ischemia, severe burns, tumor lysis syndrome, massive blood transfusion. Drugs like aminoglycoside, ACE inhibitors, potassium-sparing diuretics increase serum potassium. How do they present? Patients may present with nausea, vomiting, diarrhea, and muscle weakness. The ECG changes seen in a patient with hyperkalemia include tall tented T wave, absence of P wave, widened QRS complex, ventricular arrhythmias and fibrillation, and cardiac arrest. The treatment for hyperkalemia: treat underlying cause and preferably under ECG monitoring. Give 10 mL of 10% calcium gluconate over 10 minutes to protect the heart. 10 international units of soluble insulin in 50 mL of 50% dextrose water, or in 1 liter of 5% dextrose water to run over 30 minutes. This is to drive the potassium into the cells. Intravenous sodium bicarbonate, about 80 to 100 millimoles over 10 minutes, is administered. Other measures that are taken for correction of hyperkalemia is the use of oral calcium resonium, 15 to 30 grams 6 hourly or 30 grams rectally. Other drugs like beta-2 agonists, for example, nebulized or intravenous salbutamol, hemodialysis or peritoneal dialysis if all the above measures fail, or a patient presenting with potassium more than 6.5 millimoles. We will now talk about sodium imbalance. Normal serum sodium is 135 to 145 millimoles per liter. Hyponatremia. Hyponatremia is a serum sodium level less than 135 millimoles per liter, and they manifest clinically when serum sodium is less than 125 millimoles per liter, and they may convulse when it is lower than 120 millimoles per liter. The symptoms they may present with include irritability, features of cerebral edema like headache, vomiting, or convulsions. They may present with features of pulmonary edema. The treatment of underlying cause is employed. The correction is with intravenous normal saline and the use of diuretics. Hypernatremia. Hypernatremia is a serum sodium of greater than 145 millimoles per liter. It results from either a loss of free water or a gain of sodium in excess of water. Clinical features of hypernatremia. They commonly present with cerebral dehydration, coma, seizures, hemorrhage, postural hypotension. The treatment: restriction of saline and sodium, treatment of the pulmonary edema which the patient develops. Correction is slowly to prevent cerebral edema and hyperglycemia. The correction is by administration of normal saline followed by half strength saline and later 5% dextrose containing fluid. Thank you very much for watching, and don't forget to hit the like button and subscribe and share for updates on more videos. Thank you.